So our next speaker is I'm sorry, sir. Jim had already left the podium. Is Dr. Fred Apple, who is at Hennepin County Hospital in Minneapolis and is a laboratorian with a long history of publishing in this area.
Thank you very much. I'm the only non-cardiologist, and they leave me 3 minutes to talk, but I'll try to get my message in. Joe started off with the concept of comparing apples to oranges, and I'll present the apple point of view. But let me just ask the audience real quickly, who's transitioned from CKMB to troponin? Can I see a raise of hands? All right, so pretty significant. So I'm going to be optimistic about this high-sensitivity cardiac troponin world and view it from the concept the transition now is going to be from where you're used to troponin to another better assay with a lower analytical precision. It'll be conceptually going from that high CKMB cutoff to that lower troponin cutoff. And now we have improved the analytical parts of the troponin assay and has allowed us now to, as we've heard, provide better patient care. Now, I'm not a clinician, but I'm going to show you the market share just to show you how powerful this test has grown just in the United States. This is data lent to me by Beckman Coulter. So we've observed 30 million tests in 2003 to 42 million tests in 2008. So this is a test that is really not going away. So one thing to keep in mind, it's a very confusing area clinically. Analytically, there will likely not be any standardization between cardiac troponin I assays, the assays we use now or the new high-sensitivity assays they will go to. The major two reasons behind that analytically is there's no primary reference material, and the way the assays are designed to capture antibody and detection, there's no uniformity between manufacturers. Even if you look at the current generation troponin T and the new high-sensitivity troponin T, which is not available in the U.S., those are not even harmonized between the two. Dr. White asked a question about why high-sensitivity troponin assays are not cleared yet in the U.S. My answer to that is the FDA is struggling to understand the clinical implications along with the analytical, and they still have not given good guidance to manufacturers to set a course in getting these cleared. So this is an ongoing process. This is a busy slide, and I highlight this as many of the assays in the marketplace some of you may use. But you've heard the word in the literature, sensitive assays, not high sensitive. I think the sensitive assays that have good clinical data are the ones that I highlight. There's assays by Abbott, by Beckman, by Ortho, and by Siemens, all right? And then if we switch to the high sensitivity assay, worldwide, the only assay that's being used, I think, in clinical practice routinely is the Roche assay. It's not cleared yet in the U.S., so it's only a research assay. And then you're going to see different renditions in the literature of a Abbott, Beckman, Nanosphere, Singulex, and Siemens assay that have assay data as well as clinical data out there. You have to know your assay, as we heard about, to understand. Do not think the cutoffs for these 99th percentiles are all going to be the same. So if you're comparing apples to oranges, make sure you understand the assay data from one will not necessarily translate for the other. It's a very important point. Now, I touch on this as a nomenclaturist. I'm a chemist by training. The nomenclature of high sensitivity, we all are measuring cardiac troponin. It reflects the assay, not the protein. So when you see in the literature there's a wealth of different naming, this is a very confusing issue regarding how these assays are called. There's a special issue of the Journal of Clinical Chemistry which is focusing on cardiovascular and biomarkers. The editors, I'm one of the editors, myself, Dr. Blankenberg from Germany, and David Morrow from the Brigham, we're going to come up with a perspective and an opinion piece to put an appropriate name proposal that everyone will use consistently. And hopefully, if you have any input into this, feel free to send me an email and we'll take your ideas into consideration. Now, the areas I want to address very quickly in my presentation are the following. How we define what a 99th percentile is and how do we define what is normal. I'm going to talk about the imprecision because in the universal definition of MI, the Global Task Force, it states that an assay has to have a 10% imprecision to be recommended. And I'm going to give a little bit different opinion and hopefully influence the committee in the next writing. I'm going to talk about biological variation of assays and touch on what we've heard of this delta or change in serial orders, and then touch on a little clinical data how this impacts. So I'll ask the audience to think about, how do we define normal? Do we take all people below the age of 30 that probably haven't yet had an underlying coronary issue? Or do we take a cross-section of individuals similar to those that present to rule out an MI that apparently have normality? And this gets to be very important in where we draw the line in the sand and how we define 99th percentiles, because as we lower the cutoffs for these high sensitivity assays, I think manufacturers and investigators will be, very important to look at ethnicity, age ranges, and by gender to determine whether there's differences. What we're finding is, to do this, you minimally have to probably take 300 individuals. So if you do this correctly, 300 men, 300 women, 300 Caucasian men and women, 300 African American, Native American, so the list goes on. So this becomes a very important issue in how we define things. Now, I was involved with a study that published the largest reference determination on 4 of the major assays that are currently in practice. And what we found is the 99th percentiles for these assays were like 40 picograms, 34 picograms, 25, and less than 10 picograms by the Roche Troponin T. But a large majority of these assays did not even measure anything. That means troponin was less than the limit of detection of the assays. As we move to the high sensitive assays, here is probably analytically the best assay that has been described in the literature. It's about a 2-hour microtiter plate assay. It measures 100% of normal individuals, so you see a very near non-Gaussian distribution. If you were to look back at the contemporary assays, you can see most of these don't measure anything. You see this straight line at low concentrations. But if we move to these high sensitivity, now you're seeing measurable values. It does fit the criteria of an imprecision at 10% at the 99th percentile, but this assay would have to be translated to a box in my lab to give you, as you want, a 20-minute turnaround time. This is a 2-hour test. And you're going to find, except for the high sensitivity troponin T assay and maybe some other prototypes, a lot of these high sensitivity assays have not transitioned yet to a box we can provide timely results to you for clinical practice. And even though this study was underpowered, you get to see that men had a relationship greater concentration than women, 16 versus 9. So a larger study has to be looked at to see if this holds up. Dr. Jaffe did a study using the prototype Beckman-Coulter high-sensitivity troponin I assay, which has a lot of literature out there. This was a small population study, but the point of his study was, if you're in a hospital, we get many different types of tubes. We get plasma EDTA, plasma lithium heparin, and some get serum. And he showed with the multiple tube types, there really wasn't a statistical difference. And that's important because, again, if you're enrolling patients in studies and or in clinical practice, we want to make sure if one different tube type comes in that the results will all be similar. So as we move to all these assays, this is unpublished data. So we have an abstract that's been submitted. You can see here, looking at many of the different assays, and some of these are from the manufacturer's data, we still are going to see a difference in the cutoff. Nanosphere published some work in Germany on their high sensitivity. It was 2.4. And again, the highest one Abbott published or showed an abstract at a meeting was 16.8. Again, the number of subjects, the gender, age, ethnicity, and the statistics, which is even important, and how these were calculated were not uniform. So there has to be some form of guidance that really is very important as we move towards this process. Now, Alan Jaffe spearheaded this paper called Being Rational About Imprecision. And the reason I was part of this was part of the Global Task Force Biochemistry Group. And we generated this article, and the reason this was important is it points out that, and there's evidence to base this in the literature, that even these troponin assays with the imprecision at the 99th percentile is up to 20%. Data shows that diagnostic accuracy is not affected and risk stratification data is not affected. So the bottom line here is that the troponin assays less than or equal to 20% at the 99th percentile are still acceptable in my opinion, for clinical practice. Inherently built into determining the 99th percentile, if there is imprecision in an assay, if you look at two sets of data, and this was simulated very nicely here in a paper we did, if you take an assay that's 10% CV or 20% CV, the 99th percentile will inherently change at the higher imprecision. So that's going to be built in just the way statistics are going to be developed to determine this 99th percentile. Now, one of the things we heard about is the concern of the specificity, all right? I'm not here going to talk about clinical data, but you're going to see, as these assays improve, you're not going to have a 90% specificity. The papers you read in the literature that have high specificity are more likely than not convenience populations or very highly select groups. They're not inner-city hospital populations that I would see at my institution, where you're going to hear about all the clinical information that Dr. Newby, Dr. Albert, and Dr. Jaffe talked about. You're going to see 3 out of 10 positive troponins that are increased that the clinicians are going to have to make a decision outside what a troponin measures. Now, I'll give you a couple of clinical examples. This is one high-sensitive troponin I assay. This is looking at the timing of detection of the non-ST segment elevation MI. This is out of the Brigham group, the PROTECT-TIMI 30 trial. And clearly, you could see within 2 hours, 99% of the patients were detected with the high-sensitivity assay. Well, it was still less than 20% with an older generation troponin assay. I'm going to skip over this because Dr. Januzzi actually just showed this. Let's see, I can. It's not moving for me. All right. There we go. The other thing that was observed is a paper out of the New England Journal from the Brigham group also, the power of low measurements of cardiac troponin. This is the high sensitivity troponin T. Risk stratification in the stable coronary artery disease patients, a large group. 11% had an increase above the 99th percentile, but even within the normal range, you get significant risk stratification potential with these high sensitivity assays. Now, in a very recent study, and it was in the same issue that we heard about in the DeFilippi study, James DeLimos and co-workers showed in the Dallas Heart study of 3,546 individuals aged between 30 and 65, looking at these patients with a 6-year follow-up, 25% of these patients showed a measurable cardiac troponin T using the high sensitivity assay versus only 0.7 the contemporary assay. And you can't see this very well, but you can see a substantial increase in a rising pattern as the increase of troponin is verified. And one of the things that was discussed, if you can read the fine print, these results are presented as nanograms per mil, and you can see here it says 0.014. But if you actually pick up this is not to criticize the authors because everyone makes little typo errors, if you pick up the journal and look at the hard copy, it says 0.0014 as a typo. So one of the things that needs to be addressed for these new sensitive assays is maybe we should go to whole numbers, get away from the units, the SI units, and present this as maybe 14 picograms instead of 0.014 micrograms. Now, another big important issue is where we couldn't even look at before is if we take a look, assuming everyone in this room is normal, and we do a short-term biological variation study, meaning we draw your bloods every 4 hours over a couple of days, what we have observed with all of these assays that there's a biological variation that's measurable. Remember, we can measure almost 100% of normals. So over that 2-day period with multiple samplings, you see approximately a range of a 40 to 60% biological variation on a rising pattern, and you see about a 30 to 45% biological variation on a declining pattern, with a mean overall in the range from about 2 to 5. That means that if you see two numbers changing and it's going up only 50% using this assay, it's probably not real. It's within biological variation. So as these new data and we look at changes that occur, it's going to be very important. And what we've learned from this changing serial value, what we've called a delta, here's just a current contemporary assay. We've done some work. We actually defined a ROC curve-derived cutoff, And we found that a 30% for this assay improved specificity from 77% to 90%. And what we're going to see as we go to the high sensitivity assays, this was a nice study out of the, again, out of the Brigham group, that small changes or delta as small as 2 picograms was indicative of ischemia. And these patients were looking at transient myocardial ischemia in a stress model. So I think the imprecision is going to be very important to understand as we look at changes that occur. I kind of rushed through a couple slides because I know we got behind, but let me summarize, and I'll put this caution signs from the laboratory before you move ahead to clinical use of these high sensitivity assays. Now, for the Roche assay, which is available worldwide, a lot of these concerns are probably not going to be real because there's only been one assay. But as the troponin I assays unfold, we have to understand that assay standardization is highly unlikely for the troponin I's. I think it's important for all the assays that we define a reference population and really do that well so we can determine a true 99th percentile population. Your own populations are probably the best that you have to offer. Precision, in my opinion, I hope to work with, I'm on the global task force, and I think Alan Jaffe believes this too, as well as all the people on the biomarker committee, that assays should be acceptable up to 20% imprecision. As we look at changing delta values, which I think will also be part of this, the biological variation will be an important part of this assay-specific measurements. Keep in mind the current sensitive assays that we use can't even measure biological variation because the measurements are below the limit detection of the assay. There's a wealth of evidence building on the reliance of, for diagnostics, improving earlier detection, and then risk assessments for clinical determinants. And if most people here are clinicians, I think it's key that you find someone in the laboratory and work with them. I've been very happy and really developed some wonderful relationships. I think this is important not only in cardiology, but with your emergency department, which I find are the two biggest, really serious users and understand this the best in implementing these new high sensitivity assays into clinical practice. And hopefully, as Dr. White brought up, the FDA clears for these as they work through issues. I do not see these cleared in the U.S. until sometime in 2012. And I leave you with that and be glad to take any questions if we have time.